This week on the Backtable Podcast.
I think the mentorship aspect in the discussions around things like this, anything thoracic related, are really important. I'm available to anybody, hands down, all the time. Happy to chat about a case. We all geek out about this a little bit, right? There's just so much value in calling a friend, if you will, for a difficult case, whether it's thoracic, whether it's liver, whether it's portal hypertension, whatever, right? But the other thing is there's nothing that circumvents experience. And we both know this firsthand, right? I mean, you get out there and you do lung biopsies and you kind of notice your own workflow and what you like and what you don't like. You have to do them, and that experience comes with time a little bit. And then you add in a little bit of insight from a mentor or a friend and just continue to grow and develop.
Hello, everyone, and welcome to the Backtable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. First, a brief message from our sponsor. For over 35 years, Merit Medical has been creating confidence-inspiring tools for the IR community through understanding and innovation. Merit's newest duo of biopsy devices, the Temno Elite and the BioSentry Track Sealant System, are designed to maximize samples and minimize risk. The Temno Elite provides up to 72% larger samples than the competitive semi-automatic devices, allowing physicians to meet the demand for larger and higher quality tissue samples with fewer passes. It also includes a first-of-its-kind valve coaxial introducer intended to minimize the risk of air entering the pleural space and fluid leakage. The BioSentry Track Sealant System is the first biopsy track sealant system of its kind designed specifically to address the issues of biopsy-related pneumothorax. The BioSentry deploys a self-expanding hydrogel plug into the pleural space that creates an airtight seal following a percutaneous lung biopsy and has been shown to reduce chest tube placements by 80% and pneumothorax by 52%. Merit Medical Biopsy Solutions. Maximize samples, minimize risk. Learn more at merit.com/biopsy. Now, back to the episode. Today we got a great episode lined up. We're going to be discussing tips for lung biopsy safety and success with Venkatesh Krishnasamy. Check out prior lung biopsy episodes 278 with Dr. Robert Su and also episodes 156 and 157 with Dr. Fred Lee. Those guys get into details about their lung biopsy technique, but today we're going to be focusing on, safety and also just efficacy and success with those biopsies. Kavi, welcome to the show.
Thanks, Aaron. Honored and really happy to be here. And, this is a topic that I'm passionate about. So thanks for having me.
I like to start out the show with an introduction. Tell us, I know you just had a recent change. Tell us where you're at and what your practice looks like.
Just joined the University of Alabama Birmingham as a Director of Interventional Oncology and with a focus on IO research as well. And it's exciting. It's great. The downside for me is my wife is living and working in New York, like I said, but so we're doing a little bit of long distance for a little while, but great practice, great people, very well developed on the oncologic side. So the foundation is there, which is great for me walking into the role that I'm in, and great place to build from.
Yeah, we've had AJ Gunn on the show before, as well as John.
Oh, awesome.
Yeah, sounds like a serious IO workhorse, operation going on down there.
Absolutely.
So congrats to you.
No, interestingly, of all things, they don't do a lot of thoracic oncology, right? So, it's a great opportunity kind of for me to build up there. I've been doing a lot of thoracic stuff for a while, ever since my first job at the NIH, actually. So anyway, go ahead, please.
So that's what you'll be bringing to the operation, sounds like. Some more thoracic procedures?
Liver and lung primarily. Building the wide-body practice and the ablation practice on the liver side, and then thoracic oncology, hopefully.
And then you do a fair amount of lung ablation, sounds like?
So it's an interesting question. I think lung or thoracic oncology service line is actually one of the hardest to build in IR, unfortunately. So I got my start early on, as I alluded to just a second ago. My first clinical practice was at the NIH, and that was a great oncology practice. It was only cancer. My whole practice was cancer. The whole department was only cancer within the NCI. So that's really where I got my start, doing thoracic oncology work, and did some in Emory as well. Then I was at Columbia after that, and it just obviously radiation oncology is very strong. Thoracic surgery is very strong, and so it's a space that has a lot of players with a lot of great data, and so it is one of the toughest spaces I think to break into, and we'll get into some of that here in a bit, I'm sure.
Yeah. Well, let's do it. I do want to hear a little bit more about the ablations as well. But we're going to talk today mostly about lung biopsies. And, just to start out, we just kind of cover the basics before we dive into the more advanced stuff. But where do your lung biopsy referrals typically come from? I guess you can talk about Columbia, but also your new practice. It sounds like it's they already have a pretty robust, or I'm sure, oncology partnership going on down at UAB.
Yeah, absolutely. And so, like most things, I think everything goes to the multidisciplinary tumor board now, and that is, simultaneously, as I just alluded to, it's a challenge because I find that most IRs are not interested in going to thoracic tumor board. But if you want a seat at the table and you want to, be involved in the decision making and the planning for thoracic patients, you have to go, right? So a lot of them are vetted, discussed at thoracic tumor board, and then frank discussion about whether this can be done endobronchially or should be done percutaneously from a biopsy standpoint, and then we get patients from there.
The interventional pulmonologists, are they typically at those tumor boards?
Yeah, in my experience, definitely. But more hands on deck. That's the beauty of having multiple disciplines and being able to share techniques and literature from different spaces and understand what everybody has to offer.
Absolutely. So it sounds like most of them are coming from tumor board. Are you getting any sort of community or outside referrals as well?
Yeah, that's a great question. In my experience, we tend to bring those to tumor board as well. I tend not to, kind of silo them off to the side and see them in clinic on my own. Just that multidisciplinary discussion is always valuable, right? So more and more, we really try to bring all the patients to tumor board before and then make a collaborative group plan and then go from there. But my experience is heavily skewed towards academics. So,
yeah. At the last SR, I was talking to some docs, both in the community and in academics, about that's one of the big differences, especially in IO between private practice and academics, is just the lack of tumor board at a lot of these community hospitals, right? You basically have to go out and create your own to start to build that IO practice in private practice. Because I know, you're part of SIO and everything. Have you heard much in terms of that, like helping guys out in private practice, even some of your trainees, like, hey, this is what you need to do if you really want to be an important part of or if you want to build a robust oncologic practice?
Yeah, that's a great question. And, I spend a little bit of time in community settings as well. And it's always, forming those partnerships and, finding the applicable medical oncologist, radiation oncologist, surgical oncologist in whatever space, developing that group collaboration, kind of sharing cases back and forth, making sure that, again, everybody has a voice and, what everybody has to offer and, what they can do for individual patients. But you're right, that pathway is much less well developed, I think, in the community. But I think more and more that, perceived gap between the community and, your tertiary care academic center is starting to minimize, right? As we understand, the effects of multidisciplinary care, the importance of multidisciplinary care. So, I like to see that gap grow smaller. I mean, obviously we have work to do. There's no question. But yeah, great point.
Yeah, I mean, it seems like that's one of the big learning opportunities of going to SIO is kind of pulling some of that knowledge from guys like you and academics and taking that out into the community. So again, I highly recommend that conference for anybody that's never been. So, you see these patients in tumor board and you discuss them. Do you have a dedicated lung biopsy and or ablation clinic? How do you work these patients up? Or do you have and also do you have a dedicated nurse? Because that's also very important.
Yeah, that's a great question as well. And, I think some sort of a multi-D clinic is something to aspire to for sure.
Okay.
And we see that in kind of the HCC space and the liver space a lot these days, especially in tertiary care centers. I think that would be ideal. I think from a volume standpoint, I don't have the volume to have an isolated lung clinic on my own. So I tend to intermix them into the rest of my oncology patients. But, I will say, and I know this is a little bit controversial, there's a lot of value in seeing these patients preoperatively in a clinic setting and having frank discussions about benefit versus risk and what those risks are, as opposed to, as the more traditional proceduralist mentality, bringing him the morning of, having a conversation, 30 minutes before the procedure and then going from there, right? And so that's something that I found over the years has paid a lot of dividends for me in having those discussions in a clinic setting, whether it's biopsy, whether it's ablation, whatever.
Yeah, you're right. I mean, a lot of times you go into the room and, this is just in my practice, the way it typically was is there's virtually no conversation with the patient before procedure day. You walk in and the patient's in there and there are families in there. And A lot of times they have emphysema, and you got to talk to them about pneumothorax and expectations and so forth, and their eyes get big, and you tell them you might be staying overnight in the hospital if you have a small pneumothorax, and that this is the first that they've heard of that. So that would be incredible if we had the ability to have those conversations beforehand, and so the expectations are set, and not the day of, like you said. Is it still kind of a mix, or do you try to see almost all of them ahead of time?
Yeah, I think for a lot of practices, and I would venture to say, especially in the community from a workflow standpoint, it's challenging. Not everybody has clinic space, right? Not everybody has time when you're trying to keep up with the CT list or whatever. I'm lucky that I don't have a diagnostic role. My role is 100% IR, so that makes it a little bit easier for me, and I have more of the resources to do these things. But I would venture to say the vast majority of lung biopsies probably still just get on the table, with a quick conversation during the consent process right before. And I've kind of evolved my practice over the last several years, so definitely anything that I perceive as complex is coming to clinic first. And then, anything even mildly, remotely weird, I'm just bringing to clinic for a conversation. Something really straightforward, fine, I'll let go, especially if my clinic is full. But I'm just trying to prevent, and I've had it happen so many times, so Wednesday before Thanksgiving, and somebody comes in for a lung biopsy and, wait, I don't want to miss Thanksgiving with my family, right? Things like that. And they don't want to take the risk. And I get that, and
right.
The converse is, like I may have an air leak, with emphysema and be in the hospital for several days. I mean, I didn't know that could happen, and that's it's a lot for the patient to take in right before the procedure. And if I was the patient, I wouldn't want that, right? You wouldn't want that. And so I just think there's a better way to do it, and we're just slowly working towards it.
For those who maybe haven't done a lot of lung biopsies yet, like our trainee audience or early career audience, what do you consider a complex lung biopsy?
Yeah, it's a great question. And look, like lung biopsies are not the coolest, sexiest procedure. We know that, right? But it's an intervention that has a lot of value to the patient. And in this era where genomic sampling and understanding mutational status is really, really important, it has a lot of value to the whole multidisciplinary team in determining therapy going forward, right? So your chip shot lung biopsy is kind of the meat of the lung, not too deep, not too superficial. Totally fine. But, those deep lesions, actually the superficial lesions, and I'll show a case of this a little bit later with a more perpendicular approach to the lung, to the actual lesion, very easy to fall out of the lung, very difficult to steer towards the lesion if you miss with the first pass through the pleura. So they can be really challenging as well. Obviously bigger patients who have difficulty with certain types of position, that can be a little bit challenging. Small lesions can be a little bit challenging in CT, right? Because the needle may shatter them out completely. Long throws, long accesses across almost the entirety of the lung can be tough. So a lot of situations where it's just not straightforward.
Okay. And so when you have something complex like that, when it maybe is not as straightforward, what's your conversation like with the patients and their family before, whether it be in the clinic or the day of? What's that conversation like? What are you preparing them for?
Yeah, I mean, a lot of it is open and honest, right? And this is why we're doing this. This is the benefit of this, to get tissue, to direct your therapy going forward, and then the risk. Pneumothorax, especially higher risk of pneumothorax and chest tube placement in hospital stay with patients with emphysema. Hopefully rare risk of persistent air leak, something like that. Just openness and honesty, and they should know, and they should have the opportunity to choose whether they're okay with that risk before they get on the table, as opposed to, being told on the table, unfortunately, which sadly happens. I shouldn't laugh about it, but again, opportunity for a better workflow, and, having that conversation and counseling them on the position, making sure they're comfortable in that position. If they're not, do I need to get anesthesia involved? That doesn't necessarily mean intubation. It very well could be MAC. All of those things are easier to do in advance.
Yeah, absolutely. Do you stop anticoagulation? I guess it depends on what it is before a lung biopsy.
Yeah, that's a tough one, because we've all had those situations, and I think we're all right. I'll do a straightforward arteriogram on anticoagulation and close the artery afterwards, right? Or we can go radial. Right. I mean, those are real techniques. The challenge with solid organ biopsies or deep organ biopsies is, especially the lung. The lung is like a sponge, so you get a little bit of bleeding. It really quickly grows in that lung parenchyma. And so I really stop everything that's safe to stop.
Mm-hmm.
And, if it's really not safe to stop something, then it's a consult to my, the referring team, or a discussion with the referring team and the hematology team. And maybe that patient gets a bridging therapy and is admitted beforehand, something like that, with a hypercoagulable state or something where they need to be anticoagulated. But I really try to stop everything from a safety standpoint.
And are most with moderate sedation that you're doing?
Yeah, the vast majority. And I'll be honest, I have kind of moved away from giving the patient breathing instructions. I've kind of got used to just chasing lesions where I need to. So moderate sedation, I think, is the way to go. Every once in a while, I use MAC. Rarely I'm using general at this point. Again, I'm using a lot of CT fluoro, which I know we'll get into later. And so that allows me to really chase down lesions with the patient breathing in real time.
You keep teeing me up for these questions, man. CT fluoro was the next question.
Oh,
but
okay.
So tell us about how you use CT fluoro. I haven't had it. I worked at several different hospitals, but we had it in fellowship, which was like over 10 years ago, which it's been around forever, but not every hospital is equipped with it. And sometimes it's cumbersome depending on the tech and who knows how to do it. But once you get to know how to do it, it's pretty amazing, wouldn't you say?
I agree. It completely changed my practice. So, but I had the luxury of having it available to me day one, when I came right out of fellowship, so I'm lucky in some respects to have that. But you're right. I mean, I think every scanner has a slightly different flavor. And I think it's important to make the distinction of continuous fluoro versus your more intermittent step and shoot. And I'm almost invariably using step and shoot, right, at this point. And I think the data from a radiation exposure standpoint really supports that as well. For me, it's workflow, because traditional workflow of getting a spiral CT, stepping out, stepping in, adjusting the needle, stepping out, getting another spiral CT is cumbersome. It takes time. The intervention's longer. If you have a smaller lesion, it's very easy to just continue, miss the lesion again and again and again, right? So that's where I think CT fluoro comes in. And I think as IRs, we're all relatively impatient. And so if I can speed up the process and get the patient off the table faster with tissue safely, then I'm going to try to do that. And invariably, I get asked from my kind of junior colleagues and trainees, well, aren't you worried about the little bit of extra radiation you get using CT fluoro? And truthfully, you look at the literature, the patient gets less radiation with intermittent step and shoot, number one. And then number two, if we as operators stand at the edge of the gantry or behind a shield, we get very minimal radiation as well. And so I tend to, I'll just work quickly, move in and out of the gantry, or leave the patient in the gantry, step back. And it's really optimized my biopsy practice. And again, like we talked about, allows me to chase lesions, especially small lesions, in near real time and get tissue quickly.
Speaking of chasing, you have the ability to tilt your gantry in case, if the lesion's behind a rib or something like that.
Yeah, that's a good one as well. I do have that capability. I tend not to do that because I find it cumbersome to then reach into the gantry, when it's tilted one way or the other to adjust the needle, which I commonly do. So I've just gotten comfortable over time, kind of tracking the needle out of plane, which is what I tend to do now. And the other added advantage of that is for things like small lesions. When although I teach my trainees, to be in plane with the gantry. Sometimes when you're out of plane of the gantry, you get a little bit less streak artifact, a little bit less artifact that's going to obscure that small lesion as well. So that's the other added advantage.
On the prior episodes, which I reviewed on, actually on Back to O Plus, because it made it really easy to just get to the questions I was interested in on Back to O Plus. But the episodes with Rob Sue that we did and Fred Lee, they talked about how, and you alluded to this before, where you said you don't really do the breathing anymore. And what I always found, where the patient gets snowed, then their breathing's all over the place. They can't follow breathing commands. It's a mess, right? So I've gone to really doing light sedation. And what was interesting about what Rob and Fred both said separately was the importance of LIDO, right? Local anesthetic. Do you have any tricks when it comes to that?
I think one thing is the mentality around lung biopsy is different than like a Y90, right? Like a mapping Y90, because when I'm mapping a patient for Y90, it is like almost no sedation, or it is full anesthesia with paralysis, because I need an appropriate breath hold for the cone beam CT to target, right? There's really no middle ground, unfortunately. For this, like you said, right? Like you can really chase lesions around. It's what I try to prevent is the patient that's going to obstruct a little bit and take those big heaving breaths. Like that's what I don't want. But if they're comfortably sedated, no worries. I wouldn't even bother with instructions. But to your point, I mean, the point of pain for the patient is going through the pleura, right? That's the one place. So if you can get a 21 or 22, like with an ablation approach, that's what I'm using. I'm using a lower gauge Chiba or higher gauge Chiba, technically, I guess, and really just giving some lido or even bupivacaine right at the pleural lining right before I go through. And then, with the biopsy technique, you easily do that with just your trocar needle or your coaxial needle as well and give a little bit of lido right there. Yeah. And that helps a lot. The other place where I feel like patients have pain, obviously, when they're in a position that's uncomfortable for a long period of time, that can be a little problematic. But then when you're really torquing and steering the needle to get to a tight spot or a difficult spot, that can be a little bit challenging. I think you're just kind of levering on the rib there, and that can be a little tough for them as well. But by and large, if you really numb up the pleura well, they do great to the point that, you could argue that, like you said, light sedation or even no sedation for some patients.
Yeah. I mean, that's a great tip that you gave, that especially if you're under CT fluoro, to just go down there with a 22 gauge Chiba and just get, just kind of get that lentiform sort of covering of lido around the pleura. It's a nice image to have. And then like you said, after that, I mean, they don't really feel anything. And they actually, I feel like, you give something for their anxiety, right? Maybe, 0.5 and 1 or something like that. And just as long as they're not like snoring and trying to take big deep breaths in, usually when they're comfortable, they're just taking nice normal light breaths. So and it works out perfect. And then you're done and they're like, what, that was it. That's the ideal case, right? Talk us through like what tools you use, what kind of needle you're using, what size.
Yeah, absolutely. So I am almost invariably 17-18, and that's where I started. I mean, in my first practice at the NIH, we had a lot of lung biopsy genomic sampling protocols, and it was 16 or 18 gauge. And so, obviously I went to the 18 gauge, but that's where I started, and I just never gone to 1920 for a variety of reasons. I mean, I think, my tissue sampling is better than from a genomic sampling standpoint. I find it to be a little bit easier, to get those analyses appropriately. And I know the literature is a little bit controversial there, but, for me, in my interpretation of it, I think that 17-18 system makes sense. And then the other thing is it allows me a lot of steerability. And so I really value steerability when I'm targeting lesions, especially small lesions in the lung. And so I get a lot more steerability with the 17-18 system than I do with a 19-20 system. So that's really the other big reason that I do that. Now, and then you can also get into valved introducers and things like that, which are now on the market. I think those are also helpful from a risk standpoint. Obviously, we've all heard horror stories of, air emboli and things like that. That's helpful as well.
Yeah. And you're using one of the sort of standard side cutting needles that are on the market. There's a variety of different ones out there.
I do. That's and in particular because the, full core devices, they're a little bit heavier, right? And so when you're letting go of the device in the gantry, they can flop over a little bit. So the side core devices are a little bit easier to use from that standpoint. And then there is literature that shows that diagnostic adequacy is improved with an image, like a pre-fire image, basically, right? And so I will very commonly deploy my cutting surface into the lesion, check to make sure I like the position of it before I actually cut. And that's a nice aspect to having a side cut semi-automatic device as well.
Absolutely, yeah, that's what I do too. And it's refreshing to hear you say that you use the 18 gauge. I'm the same way. I learned it later in practice. So when I was a couple years out, I was rotating through a hospital where my partner was like, I think I had like maybe a non-diagnostic biopsy come back using a 20, and he was like, just use an 18. Like it's the same. The literature shows virtually the same in terms of pneumothorax risk, and you're just going to get much better biopsies. And when I made that change, I actually had that happen in my practice where I just felt better about the biopsies I was obtaining, unless it was like something tiny, like a little sub-centimeter or ground glass nodule. I might go down the size, but I traditionally will always go with the 17-18, like you said.
And to your point, I mean, that there's nothing that substitutes experience like that, right? That involves our practice individually. That, us having this conversation may not change it as much as you going out or me going out and trying something or doing something different and having a good or a bad experience, right?
Absolutely. Absolutely. And so along those lines, in terms of, getting adequate sample, do you have a pathologist or cytotech that on site or, during the case to verify that you have sample?
Yeah, that's a great question. I've worked in practices with both. I will say I do value having a cytopathologist in the room, and it's not for the typical function, right? Because the challenge in these situations, especially with small lesions, is it's very easy to get a little bit of bleeding around the lesion and then lose the lesion. That's another reason I'm such a proponent of CT fluoro. So I'm very commonly, it's snap, snap, snap. I take 3 or 4 very quick samples with imaging to verify needle position and then just giving it to the cytopathologist.
Oh, interesting. Okay.
So I'm not actually waiting for them to take a look. Like I said, I don't want to lose a lesion, unless it's a large lesion. But the function for me is when I go back to tumor board, number one, I have an image with a needle in the lesion, and then I have that cytopathology early interpretation, which I do wait for before I get the patient off the table, to show that, this is what we were dealing with intra-procedure. So in the rare event that it comes back, inadequate in tumor board, then I can at least show that. And I think that's helpful context. What I really don't like is when people come back to tumor board and there's no imaging showing the needle in any position. They just kind of blindly fired it, and now the tissue sample is inadequate. Well, did we miss, or is it just a necrotic lesion or something like that? I think it's a little bit challenging to tell in situations like that.
Yeah, definitely documented with images for sure. I think that is something that everybody drills into you almost to a fault, right? Almost to a fault, especially with fluoro images.
Absolutely. But you'd be surprised. I see that not infrequently. Like somebody feels like they're in a good position, I'm going to just take a sample. I'm not trying to degrade that, to each their own, but it's something that I value in my practice.
Yeah, absolutely. Absolutely. I don't know if you listened to the episode with Chris Beck where he had one of his pathologists on, and he was saying that, sometimes the radiologist will come to him and be like, but the needle is in the lesion. And he's like, yeah, I see that, but the lesion is not in the needle. I just thought that was funny.
Yeah, that's one of the challenges. It happens. It totally happens. And I think that's where there's a lot of value to having a cytopathologist in the room, because if I have a larger lesion, then I'll just go and redirect and find another spot. And I have no problem, as long as I'm not puncturing the pleura, multiple times, I have no problem doing that. So there's a lot of value in having a cytopathologist in the room for sure.
Absolutely. Absolutely. So after you've gotten your samples, and you're usually taking 3, 4, I guess depends on the size of the lesion, and what helps you determine how many samples to take?
Baseline 4 to 5, I would say. And I will confess that, at least in my practice and my experience over the course of the last 10 years or so, I have not had issues with taking, 4 samples versus 9 samples or 10 samples, things like that. So, there's always that concern. Well, more samples means more risk, but I have not really seen a lot of that. Yes, you can get a little bit of bleeding, you can obscure those lesions, and then maybe you can't even get 4, 4 samples baseline. Obviously there are protocols, tissue sampling protocols that require a little bit more. If I need to take extra passes to get a diagnosis or to make the cytopathologist a little happier, I'm happy to do that. That doesn't really dissuade me from getting, 8 to 10 to, 12 samples if I need to. I know that sounds crazy, but what I don't want is for the patient to have to come back a second time, right? So.
Absolutely. Yeah, absolutely. Well, speaking of that, one of the reasons why we don't take more samples is we're afraid of pneumothorax, right? So what are you doing in your practice? Are you doing blood patching? I mean, we had Fred Leon, who's a big promoter of blood patching, gave his whole algorithm. And then we also have had Robert Suhan, who's talked about the hydrogel stuff, which I think has maybe evolved over time. What do you do in your practice, and maybe give us reasons why?
Yeah. And, I'll confess, I have not had this conversation with Fred before. I have had this conversation with Rob earlier in my career, just, kind of getting a sense of, what he likes to do. And so I'm a big proponent of the plug, and the blood patch technique has just been, I found to be a challenging workflow in my practice, from drawing in advance, or if somebody forgot to draw it, then having a big enough IV to draw it afterwards, keeping it sterile, having it ready, and so I've just found value in going to the plug. I know there's extra costs associated with it, and so sometimes getting it through your local VAT or whatever can be a little challenging. But I went to the plug years and years ago, and was lucky to have it in my first practice, and noticed a dramatic improvement in my outcomes when I used the plug. And so I've gone to the plug a long time ago, and I use it almost exclusively. It also depends on the situation, right? If you get a small pneumothorax upon entry into the lung, I don't stop. I will, put a tube or a drain or a UE or something in the lung, reinflate the lung, and then continue with the biopsy. But by and large, on the way out, I'm plugging my tract.
Pretty much every time?
Every time. Yeah, every time. Yeah. Yeah. Invariably. The plug is 2.5 centimeters. So maybe the only time I won't plug is if my needle tract is, very short, 1 centimeter or something like that. That's rare in my practice, but that would probably be the only time that I don't plug.
How do you deploy it actually? How does it work?
Yeah, so it comes with, you kind of screw the plug onto the back of your introducer, and then you set the depth on the pusher rod for the plug. And apologize, I don't have a picture to show at the moment, but you push it to that depth, and then you kind of pin pull your coaxial needle to deploy the plug at that set depth, which is usually right across the pleura. Now, the one added nuance I will say is, and credit to Rob for this, because I think we were both thinking about this a little bit, but he was the one that verbalized it, and it really kind of solidified it in my mind. We talked about workflow and optimizing workflow and efficiency in the room with CT fluoro and moving quickly. The one part of the procedure where I'm purposefully not moving quickly is the plug part, actually. And the thought process being that as you deploy your plug, if it's not had a chance to really expand, sometimes you can leak air around the unexpanded plug and give yourself a small pneumo that way. And so I purposefully give it time, wait, let it sit, and with the theory that it's interacting with some of the materials or the fluid and blood products in the trocar, the coaxial needle, and starting that process of expansion and preventing pneumothorax when it's actually deployed. And incidentally, I found when I changed my technique, my outcomes got better. Now, this is not published anywhere, but I found that my techniques got better.
Yeah, no, that's a great tip. Any other kind of pitfalls, or is there much of a learning curve when you first started doing this, or you're teaching your trainees? Anything that you've noticed where they kind of struggle with?
From a lung biopsy standpoint, or just the plug?
Well, no, in terms of the plug, yeah. Because I think people get like that's, for example, for me, like I always have done blood patches because I know how to do it. It's easy. I know how to squirt it in. I'm like, there's not much you can screw up. The sterility piece is true. The setup that's kind of a nuisance sometimes, but you can't really screw it up really, and,
sure.
And with the plug, I'm always like, well, I don't know. I don't want to screw it up, and unless somebody walks me through how to do it, I'm just going to keep doing the blood patches. So that's what I was curious to know if there's anything that I need to even be worried about as a doctor out in practice.
Yeah, that's a good point. It is such an easy deployment to me that it's almost like see one, do one with supervision, and do one kind of. Yeah, right? Yeah, exactly. Teach one. That's what it is. Sorry. I don't think it's challenging. It's easy. I've walked people through it over the phone, on video calls. Like it's very straightforward. The only nuance is that if your depth to the pleura is over 7 centimeters, there's a max deployment length that you have with the device. That's 7 centimeters. So there are a little bit of ways to work around that, though, probably beyond the scope of this. But, you can also deliver it and then kind of pin pull it with your actual coaxial introducer needle, as opposed to using the pusher rod, things like that. So there are other ways to kind of work around that. But otherwise, it's a very straightforward, very simple deployment. I hope my fellows think that it's the easiest part of the procedure, but I guess I've never asked. That's a good question.
Cool. Well, now that you've got the plug in, what is your post-procedure algorithm? I know some people are like, oh, chest x-ray 1 hour. And then if they're good, like for me, chest x-ray 1 hour, if they're good at 2 hours, I usually let them go between the second and third hour, as long as they're feeling okay. I've heard everything from letting them go because they're doing fine to 5-6 hour post-procedure. But be curious to know what you guys do.
Yeah, sure. So I think first thing, if there's no pneumo on the immediate post-CT, I always get an immediate post-CT. If there's no pneumo on the immediate post-CT, there's nothing, there's no reason to me to get a chest x-ray immediately. So I'll skip the immediate chest x-ray. I'll get an x-ray 1.5 hours, 2 hours, something like that. If it looks good and they feel fine, I'll let them go. Small pneumo, or, definitely get an immediate chest x-ray. Oftentimes I'll actually put a UE or a small tube, try to suck out the pneumo, and then flip the patient to, that biopsy side down, or and try to seal the kind of lung against the pleura, as we know from the literature, and then get that immediate chest x-ray and kind of go from there. Moderate to large pneumos, usually get a chest tube in the room, and we'll probably just get, go straight to admission, something like that. The quandary, I think, is what do you do with the patient that has no pneumo immediately, but then develops a pneumo within that, or on that first x-ray? Obviously anybody symptomatic, moderate to large, needs a chest tube, but we have variable access to CT in a lot of practices. I'm actually in a practice now where the CT scanner is shared amongst multiple diagnostic services, which is a little bit of a new thing for me. If you think about it, when the patient is supine, the most non-dependent part of the lung is actually the lung base, not the lung apex, right? And so it's actually very easy to put a patient on the fluoro table, visualize the pneumothorax kind of low in the chest, and then just stick the air and drop a quick chest tube in fluoro without having to go to CT. And so I very commonly do that. And then the other advantage of doing something like that is I'll direct the needle upward, and I'll show a picture of this later, and I'll drape the chest tube over the apex of the lung. So then when the patient sits up, all that non-dependent air rises and goes right to the tube, right? So I think that's a little nuance that a lot of us get stuck in, thinking that we have to put chest tubes in CT. In reality, it can work very well in X-ray as well.
Absolutely. Yeah, that's a great protocol. Any resources for trainees or docs out there looking to learn these sort of advanced techniques for biopsy and or ablations?
There are a lot of ways to think about this. I think the mentorship aspect and the discussions around things like this, anything thoracic related, are really important, right? And so I'm lucky at my stage in career that, if I have a difficult case, I'll call Rob. Rob's been great, for a source of information and just chatting and getting ideas and getting feedback. So those things, I think, cannot be understated. I'm available to anybody, hands down, all the time. Happy to chat about a case. We all geek out about this a little bit, right? So there's just so much value in calling, phoning a friend, if you will, for a difficult case, whether it's thoracic, whether it's liver, whether it's portal hypertension, whatever, right? Obviously, there's literature, but the other thing is there's nothing that circumvents experience. And we both know this firsthand, right? I mean, you get out there and you do lung biopsies and you kind of notice your own workflow and what you like and what you don't like. And so you also you have to do them, and that experience comes with time a little bit. And then you add in a little bit of insight from a mentor or a friend and just continue to grow and develop. But that's true for most things in IO. I think the other thing I'll say is, I very firmly believe that, as an IO, that we have to be able to offer multiple therapies in the space, right? So I think it's challenging to be an IO in liver and offer Y90, but not offer ablation, right? How do you know when is the right person to send for ablation, or when you would ablate a patient if you're only transarterial, and vice versa, right? So I think there's a lot of value in this scenario. I can offer lung biopsy, I can offer lung ablation. Understanding the technologies, understanding the devices. I cryo and I microwave in the lung. I'll do both depending on where the lesion is. And so, but I have my thresholds for where I would do each of them, and so understanding what you like, what you don't like, what the devices can offer, where the pitfalls and pros and cons for each device are, is helpful as well.
Yeah. Well, Kavi, thank you so much for sharing that. We saved a little bit of time to show those cases.
All right. So I think access is really important, and I'll start here. And so this left-hand image is kind of more superficial lesion that I alluded to earlier. These can be really challenging sometimes. And so I do not take that perpendicular approach into the lesion, like we said, because the needle can fall out with a little bit of breathing. And then number two, if the patient takes a breath as you advance to the pleura and you totally missed, you have very limited ability to steer that needle to the right place. So I don't like that perpendicular to the pleura approach. I take a more parallel or tangential, or what I like to call an ablation type approach. And the reason I say that, if you're ablating this lesion, I don't know if you can see my mouse, but if you're ablating this lesion, the ablation zone will go back along the needle, right? And so if you take this perpendicular approach and you have a very short distance between the pleura and the lesion, you're 100% going to ablate back into the pleura and then the soft tissues. So for multiple reasons, I take that kind of tangential parallel approach. Now, the converse is true for your depot lesions. So in these lesions, I like to be perpendicular to the pleura and then parallel to the vessels to avoid them and hit those central lesions. And this is a lesion that I went after. Didn't dissuade me, given that it was more central around larger vessels. And, we got tissue, right? So definitely doable, slightly higher risk, but definitely doable. And, with things like CT fluoro can track it in space. And so these are just a couple examples of CT fluoro. And, Aaron, please stop me at any time with any thoughts. But this is what my workflow looks like. I'm just standing there and slowly dropping the needle, and you'll notice I kind of punch through the pleura and then kind of verifying my cutting surface in the lesion. And this is a relatively straightforward one. Now, this one, I will say, is more of that sub-centimeter lesion. And so this was a little more challenging in terms of tracking it with respiration like we talked about. But again, to me, the workflow is much easier in CT fluoro as compared to getting a spiral CT, stepping back in, adjusting, stepping out, getting another CT. And you'll also notice as soon as I take this first pass here in a second, you start to get a little bit of blood, right? And like we talked about, you tend to lose the lesion.
Lose it, yeah.
Yeah, so those first couple passes are really, really important. So I don't like to wait to give a pass to the cytopathologist. I'll take 2 or 3 quick passes, verifying needle position, and then give them all to the cytopathologist at the same time.
Yeah, that would have taken forever if he didn't have CT fluoro.
Exactly, right?
To get
exactly.
that needle position.
Exactly. And then, so this is that kind of pneumothorax workflow that I was kind of alluding to, right? So this is a post-biopsy x-ray. I tend to get a lot of them in exploration just to really highlight the pneumothorax. Obviously, there's a pretty decent sized pneumothorax here on the left side, on the left image. And then this is the fluoro image on the right side. Put them supine on the table and you see that huge area of air at the base of the lung, right? So really easy to kind of stick that area. And then, like I said, I just deliver the tube over the apex of the lung. I will often use a biliary drain for the extra side holes, and then I'll often de-string the drain as well to make it easier to pull out. And then I'll commonly use anywhere between a 10 and a 12. I rarely use an 8 French drain these days. So just something to think about. I think a great way to optimize positioning of the tube and kind of move that protocol of getting the tube out, make it as efficient and fast as possible.
Does the 10 or the 12, do you feel like that helps it resolve faster? I guess what's the reason for the larger size?
Not necessarily. I just find that it kind of falls down alongside the lung less, number one. And then number two, it's less prone to kinking or twisting as the patient is moving around, just a little sturdier. So I just tend to automatically go to 10 or 12. And I've just had so many issues with 8 in various parts of the body, not just in the lung over the course of my career. So what do you like to do?
No, I always think, 8 is for air is the common, saying, but meaning like you don't use it for any kind of fluid. But yeah, I got away from 8s, basically minimum being 10s for most things. But I was just curious if there was like some reason for, some positive reason. Like you said, those are great reasons to do it. I also had commonly issues with 8s, and sometimes they would give me one of those 6s and I just put it in because it was that, it was what was in my hand. And those cause all kinds of, talk about kinking, especially on an obese person. Like there's just no point in putting a 6 in.
I totally agree. And, and I incidentally, like whether you put an 8 or a 12, the drain is still in contact with the pleura, which is irritating for these patients and they get a little bit of pain.
Right.
So I don't find that, there's any more pain or anything like that. It's, any tube is going to cause a little bit of irritation there. So I'd rather just get the tube out faster. And obviously if the 8 kinks or falls to the side of the chest or something like that, then, they need a tube replacement up to the apex. Then it's just a longer hospital stay with the tube for them, right? For the patient. So
yeah, makes sense.
So this is the last one I'll show. And I think this is a good example of what we can bring to the table. I mean, this is a case that came to me just for diagnosis because the interventional pulmonologist wasn't able or didn't think he would be able to go after this lesion. Now, I know full well that that's variable in different places. And, there are certain places where interventional pulmonology would be very aggressive and get this lesion as well. But the local site just wasn't comfortable going after this. So this came to me. And this is a fairly central lesion. I don't know if it shows well, but, right on top of the pulmonary artery, right? And I think, we discussed this internally in the group. And I think a lot of people would be reticent going after something like this. But I do think we can safely do this. And yes, there is, look at the biopsy picture. This is not the greatest picture. There's a lot of, parenchymal hemorrhage along the tract, but this patient, to his credit, didn't have any hemoptysis. We did get sampling and he was able to go to surgery actually with the thoracic surgeon. So a good opportunity to highlight what we can offer just from a biopsy, right? And I think that's where this gets into the discussion of hemoptysis. Have you ever had a biopsy start hemoptysizing on the table?
Yes. One of the scariest cases I've ever done, honestly, because they look like they're just vomiting. They're just coughing up blood and it's all over the place. And it's like a horror movie. It's crazy.
Exactly. It is. The first time it happened to me, it was like a change your shorts kind of moment, right? You're so scared.
Oh yeah, absolutely.
I'm going to name drop a little bit here. So Richard Chang is an old partner of mine from the NIH. He's retired now. Richard, if you're listening, I hope you're enjoying retirement. So he had this little technique where he would take, and this is totally not data-driven, I know that, but it's saved me more than once or twice. Take a gel foam pledget, soak it in a little thrombin, and then just have it in a 1 cc syringe just on the table ready to go for situations like this. And so I've had a couple of patients now, actually I've had more than a couple of patients now that are starting to hemoptysize on the table, needles in the chest, they're wiggling all over the place, and then just take that little pledget and fire it through your coaxial needle. And it's amazing how quickly things can resolve. Obviously, you can't see the small vessels that you hit along the way. So that's a little technique that's kind of bailed me out more than once. But you're right. I mean, that situation of having a patient hemoptysize on the table is one of the scariest, and something that I will talk about with the patient preoperatively almost invariably now.
Yeah, we should almost do a whole episode just on that, like what to do. I mean, immediate things are you place them on that dependent side, right? I had it happen a couple of times. One of which we placed him on the side, got him off the CT scanner, and he stabilized pretty quick. But it's still, it was during COVID, so he's filling his mask with blood. I mean, it's just a gruesome scene, right? But it resolved pretty quick. And then the other one was, we had to call rapid response because she actually got desatted, hypertensive, and pulmonary came in and actually saved the day. Both very scary. And that's the whole thing is you think of it as this routine procedure because we might do 5 in a week, sometimes more. You might do 2 or 3 in a day sometimes. And you're just like, okay, another biopsy, whatever. But that happens and you realize how it's risky real estate. And we do have to be careful. And having little tips like you just mentioned can be lifesavers, literally. And so that's a great tip. Appreciate it.
No, I mean, thank Richard. I mean, that was, he taught me that 10 years ago, and I've kept it with me this long. And, little things I think that highlight what we learn from each other, right? You're never going to find something like that in a textbook. It's never going to be in an article. It's always like discussions like this. Oh, that's a great idea. I'm going to try that the next time I'm in the middle of a case. And, it's a space that, although you and I have a lot of experience here and we have a lot of passion for this space, there are a lot of IRs that are just uncomfortable in this space. And it's, I think, just not having a lot of experience, right? Which can easily be rectified, but it's incumbent on the individual to take those steps, ask those questions, things like that as well, right? But as we continue to move forward, from an IR standpoint, I really hope more people take an interest in thoracic oncology.
It's a rapidly evolving space, and we didn't get to ablations, but that's another topic we want to cover here very soon in terms of lung ablations. And just to let any trainees or early career docs know, in residency, I assisted, let's say, in maybe a handful of lung biopsies, and then in fellowship did maybe 2 because we were so focused on what was going on in the cath lab, right? Not CT guided procedures in my fellowship at least. And so it wasn't until I got out in practice where I got the high volume of lung biopsies under my belt and learned all these things. So don't be discouraged. I mean, it seems kind of rote, but at the same time, there's a lot of like little tricks that you're going to learn along the way. But you're right. Just that's what I love about Backtable and the podcast is being able to crowdsource this kind of information from you, Fred Lee, Rob Sue, who are the masters at this and really getting this information out. So Cubby, appreciate you coming on the show, man.
Appreciate the opportunity. It was a wonderful time chatting about this. And I'll make one last point. I think what you said is very, very important, Aaron, because just like you, I didn't do any biopsies in training, in fellowship especially, right? And so my first practice was like biopsy overload and getting used to ultrasound guidance and all these like little things that are second nature now. And totally. Like, don't be scared about it. Ask questions, and everything comes with time. Absolutely.
Perfect. Thanks so much, Kavi.
Appreciate it, man.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_Backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer,
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.